Hello, and welcome to MIT Sloan Alumni Online. Every month, MIT Sloan Alumni Online brings you the latest breaking news, cutting-edge research, groundbreaking ideas, and school updates from MIT Sloan faculty and alumni. Today, we have Paul Osterman joining us. Professor Paul Osterman is the Nanyang Technological University Professor of Human Resources and Management at the MIT Sloan School of Management, as well as a member of the Department of Urban Planning at MIT. From July 2003 to June 2007, he also served as Deputy Dean at the MIT Sloan School. His research concerns changes in work organization within companies, career patterns and processes within firms, economic development, urban poverty, and public policy surrounding skills training and employment programs. His most recent book is Who Will Care for Us? Long-Term Care and the Long-Term Workforce, published in 2017. Paul, we're excited to have you joining us to tell us more about your work and long-term care. I will now turn it over to you.
Thank you, Greg, and thank you everybody out there for joining us. Let me actually begin just by apologizing for my voice. I have a pretty heavy cold, and so I'm going to kind of cough and sputter my way through this. But on the other hand, I'm probably not contagious to you. So I'm going to talk to you about my book on long-term care and some of the findings in that book. I should begin by just saying a word about how I got into this. I'm a labor economist, and a great deal of my research over the years has been about low-wage labor markets and how to make jobs better for people who are earning very low compensation. It turns out, and I knew this, that a very large number of low-wage workers are in the healthcare sector, and a very large number are involved in long-term care, either taking care of people in their homes or in nursing homes. And so I decided I should kind of study low wages in that sector and think about what to do about it, what kind of policies might make a difference. I discovered two things as I got into this. First, I discovered, and I'm sure I should have known this, but I did discover it, that you can't really answer the question about how to improve these jobs without understanding the whole system. And the system, as I'll describe in a few minutes, is baroquely complicated. And also actually quite fascinating and quite interesting. But I put a lot of time into trying to understand the system, who are the actors, what are their incentives, what are the potential levers for change, and importantly, what are the consequences for clients of the current system and how one might improve the system. So I got interested in long-term care per se, not just in terms of the workforce. The second kind of discovery I made, I had never worked in healthcare before, done any research, is that healthcare is a field in which virtually everybody I talked to was welcoming. People wanted to talk about what their jobs were. They wanted to talk about how it could be improved, what they saw as the challenges. They were happy to essentially donate their time to me. And so it was a really pleasurable task. So let me begin, assuming I can manage this technology, by talking about this. So the plan for this talk, I'm going to begin by making a few comments about the long-term care system as a whole, and then I'm going to talk about the workforce issues. Now, when we talk about long-term care as a system, it's not a system. And one of the things that happens, of course, is when I give this talk to different audiences, there's always people in the room who have had experiences with this system, and they understand it's not a system. Consumers don't really know how to access care. Should you go to an agency? Should you try and find a network of people who do it? Should you call a nursing home? How should you do it? We researchers and people who are policy wonks in this field actually don't have a good grip on how many people receive care or where they get it. We are confused about how people pay for getting their care. And this next point is fundamental to the argument I'm going to make. Long-term care is simply an afterthought in the healthcare system as a whole. And I'll talk a little bit more about this, but it is not taken that seriously by the powers that be in the system. And the consequence of that is that the system is not nearly as good or effective as it could be. And then the workforce issues, which will be the main focus of this talk, are quite serious and not well understood. So, a couple of facts about the system. How many people need help with long-term care? And I should say, by the way, that although a lot of what I'm going to talk about is going to be about elderly, people 65 and older, and the reason for that is because their numbers are going to explode, and that's going to put a lot of pressure on the system. As a matter of fact, about half the people who receive long-term care are young people who are born with disabilities, young people who are hurt in accidents, get ill. And that's important to understand. It's not simply a system about the elderly. And it's also, as you'll see, important in terms of the politics of the system. So about 10 million people who receive long-term care, about 20% of the population 65 and older, and about 13 million people under 65, about 7% of that population. So crudely speaking, about 23 million people today in the United States receive long-term care. That last line, HIPAA, the reason your doctor can't talk to anybody but you, HIPAA standards are used for eligibility for Medicaid or Medicare long-term care, and those standards are tougher. And so the numbers who are HIPAA eligible are lower, but that's kind of inside baseball. The fact of the matter is that about 23 million people today are receiving some form of long-term care, not necessarily paid care, but long-term care. Where are these people getting help? About 1.5 million in nursing homes, about 1 million people in assisted living. We don't know. This is another bizarre fact about the system. We don't really know how many people are getting help at home. Medicaid, which I'll describe in a few minutes, Medicaid reports that about 3 million people got long-term care. I'm sorry for the acronyms. HCBS is home care, basically, community care. But lots and lots of people are getting long-term care not paid for by Medicaid, and we don't track those people. But it's clearly the numbers of people getting paid care at home is above the sum of people in nursing homes and in assisted living. And the data are clear and people's preferences are clear. People want to stay at home. And so the relative proportions are going to shift increasingly towards care at home. Who's paying? The conventional story, and in all the policy literature and in congressional hearings and so on, is that over 65%, or about 65% of long-term care is publicly funded, with Medicaid being the elephant in the room, or the gorilla, whatever the metaphor is, paying for most of it. Medicare, some of it, other public fundings, for example, state programs, and out-of-pocket or private insurance being trivial, or not trivial, but relatively small. Now, let me say a few words about the financing here. To be eligible for Medicaid, you have to have a low income level and a limited amount of assets. And it's complicated, it varies by state. Medicaid is a federal state program, and different states have different standards. In most states, you can keep your home, but you can't have many assets beyond that, and your income level needs to be quite low to be eligible for Medicaid long-term care. The fact of the matter is that if you engage in estate planning, or you have a lawyer and you set up various kinds of trusts, and you do that with 5 years of advance notice before you need long-term care, or your mother needs long-term care, you can find ways to make yourself eligible for Medicaid. Medicaid, and if you're in a nursing home, overwhelmingly people in nursing homes are on Medicaid because they spend down. Nursing homes are so expensive. Medicare is not designed to provide long-term care. It provides assistance at home for people after acute episodes, after they leave a hospital, for example, for up to 90 days. Now, it's possible to string some of these together, and many people who need long-term care don't need it for years and years. They need it for short periods. And so as a matter of fact, Medicare does provide some long-term care, but it's complicated. It's not designed to do that. Private insurance is plummeting. Only about 6%. It's only responsible for about 6% of the cost. The number of people who get private long-term care insurance is declining because it is so expensive. and then there's out of pocket. So this is the kind of the standard view of the world. I think this view is wrong. I think that there's much more of a role for out of pocket that's not tracked in the government figures. And the way you can see that is there are a number of surveys out there that ask people who are getting long-term care how they're paying for it, and is any form of insurance paying for it. And only less than half the people report that any insurance is paying for it. And based on this, the federal government, ASPE is a research operation in the Department of Health and Human Services, estimates that about 65% of paid home care is out of pocket. The reason this is important is because one of the pressures on the system, which I'll talk about down the road, is going to be people can't afford this. It's incredibly expensive. The estimates are if you need a nursing home, you're going to pay close to $100,000 a year. If you need full-time long-term care, you're in the high 40s, low $50,000 a year. Most people can't afford this. And it is largely out of pocket. Medicaid is important. Medicare, in a kind of a backdoor way, is important. But people are suffering. They're paying a lot of money out of pocket. I told you that it's not really respected by the healthcare system. Gerontology is the lowest paid specialty. When it comes to home care, there are very, very few standards, very few quality controls, even for federally, when federal money or state money is involved through Medicaid or Medicare. And there's very little research on the topic. What's the best way to deliver long-term care at home? What forms lead to the best outcomes? What design of work systems lead to the best outcomes? As I'll say again, healthcare is a system in which there's a gazillion random assignment trials for every kind of intervention that you can imagine. There's virtually nothing when it comes to long-term care. It's simply not taken seriously. Most of my work is on the direct care workers. Direct care workers are the people who take care of you at home or take care of you in a nursing home. And I'm going to argue to you that thinking deeply about the role of these aides, these direct care workers, offers a strategy for improving the system as a whole and making it more affordable to clients. And as I said at the very beginning, improving the circumstances of these aides is part of a larger strategy aimed at doing something about the size of the low-wage job market in this country. So what are the workforce challenges? One challenge, as I'll say and indicate in a minute, is low wages. The next challenge is long-term care workers often lack the skills that they should have to do a great job. And there's tremendous shortages, and the shortages are simply going to explode. So how many of these direct care workers, paid long-term care workers, are there? Home care aides, which, by the way, I'm using the term home care aides. If there's anybody out there in TV land who is an expert in the system, you know that there's subcategories of home care aides, but I'm ignoring for this discussion those distinctions. There's about 2 million paid home care aides out there. A lot of people get help under the table. By that I mean they're hiring somebody informally, and that person may or may not be reporting to the IRS that they're working as a home care aide. It's very hard to get estimates of the number of these folks. I have come up with an estimate, and I won't describe to you how I did it, but I'm feeling good about the number. And I estimate there's about 300,000 under the table aides, and there's a little bit over a million certified nursing assistants, some of whom work in nursing homes or assisted living, and some of whom actually do work as home care aides. So we've got about roughly 3.5 million of these folks out there. How much do they earn? What they earn is terrible. So the mean annual earnings for a home care aide is almost $18,000 a year. That's a poverty wage. Certified nursing assistants do a little bit better because nursing homes pay a little bit better. Even the average is $21,000, still a poverty wage. And so when we come to the question of shortages, and what we're going to do about there not being enough of these folks to take care of the elderly, explosion of the elderly who need help, remember how much they're paid today. That's a huge problem. And I'm going to talk about how to improve that. Who are they? They're overwhelmingly women. Nationally, about 27% are immigrants, but that varies tremendously by the part of the country you're in. In New York, city, it's about 2/3 immigrants. In California, it's about 50% immigrants. In Ohio, it's about 8% immigrants. So there's a lot of variation. They're disproportionately people of color. And importantly, almost half have at least some college education. A year, less than a year of college, but something. And that'll be important as I keep talking. So why is compensation so low for these folks? The standard story is that it's because of reimbursement rates. To the extent that people are getting long-term care through Medicaid or Medicare, agencies can only pay people what they're reimbursed for. And those reimbursement rates are set by state officials for Medicaid or by federal officials for Medicare. They're politically set, right? They're not determined by supply and demand in the market. And Medicaid is under tremendous pressure in every state because it's very expensive, not just for long-term care, but for everything. And it's competing for state money with education, with public safety, with all kinds of other good uses. And so every state is tamping down its reimbursement rates for Medicaid. And basically, an agency can't pay somebody what they don't get reimbursed for, and that holds it down. Now that's important. And it does point to a way to address the problem, but it's not the whole story. And the reason it's not, you can tell it's not the whole story because a SNF is a nursing home. Well, about 61% of people who are in nursing homes are on Medicaid. If in assisted living, only 20% of people in assisted living are on Medicaid, and Medicaid doesn't pay for the aid in any case in assisted living. Yet the wages in assisted living are just as low as the wages in nursing homes and home care. Something else is going on in the system. I'm going to actually skip this slide and then come right back to it. One of the things that's going on in the system is attitudes, culture. And culture is something that economists don't think about that much, but it really plays an important role in this field. The quote, "These are minimum wage people," came from an insurance executive who I interviewed when I asked him about how strategies for improving the circumstances of the aides and whether they could do more. What if, when I discussed with a public health nurse who's an advocate for improving long-term care, what about a strategy of training people, home care aides, more so that they could do more and be more productive, which I'll come back to. The nurse replied, "But what if they put the cat's eye drops in the client's eye?" Just kind of contempt for these folks. Last quote is a quote from a focus group I ran with aides. Most people, when they hear we're home care aides, they look at us like we're scum of the earth. I try and tell them certain things about the client, and they act as if they didn't hear anything. There's tremendous kind of cultural bias against these folks, that they really are minimum wage people who really can't do very much. That's part of the story. The other part of the story is that returns to skill are low. This is based on a regression, a statistical relationship between education level and earnings. And if you get a college degree or have some college and you're a home care aide or a CNA, you get a small boost in pay. And two other low wage jobs, retail sales and waiters, waitresses, you get a much larger boost in pay. And the reason for that is that these home care aides are not given an opportunity to be more productive. They can't do more. Why can't they do more? They can't do more for three basic reasons. One is the hierarchical nature of healthcare. They're not treated as part of the healthcare team typically. Doctors and nurses ignore them. And I heard many, many stories from aides I talked to. They would accompany their client to the hospital. They knew their client. They knew their client's issues. They would try and talk to the doctors or the nurses about what was going on, and they would be ignored. That goes to the bottom point also, the scope, the culture of medicine. The middle point is central, scope of practice. Every state has what's called a Nurse Practices Act. And the Nurse Practices Act limits to nurses a range of activities, and no one else could do those activities. As I'll argue, many of those activities could be done by home care aides, but they're not legally allowed to, with the consequence that they can't be more productive. And I'm coming back to that. As I've already told you, long-term care is a policy stepchild. There are no serious home care demonstrations. There are a few demonstrations for nursing homes, but only a few. And if you talk to policymakers, and I talk to a lot of policymakers at both the state and federal level, they're focused on fraud, they're focused on finances, they're not focused on improving home care or improving the jobs. Now, none of this is going to be viable going forward. This is the crisis we're going to face. The baby boom is going to age, and family caregivers are going to be, unpaid family caregivers are going to be less available. And that's going to exacerbate tremendously a shortage of these direct care workers. So these are my estimates. On the right, the growth of the population 65 plus is the census estimate, not mine. And you can see that you know, as everyone except me gets older, that population is going to explode. The column on the left are my estimates of how much the direct care workforce will increase over these periods if nothing has changed. If the compensation level of the aides relative to other jobs with which they might take isn't changed, or the scope of practice isn't changed, this is what the growth rate will be of direct care workforce. And you can see that there's a huge gap between demand and supply, and that's going to be a fundamental crisis. Turnover is part of the problem. If you talk to a nursing home or you talk to a home care agency, they will tear their hair out of turnover, about turnover. Part of it's because there's an unstable workforce. These are poor people. They don't make much money and their lives can be chaotic. Partly it's because people move and go to better paying industries. You can now make more as a retail clerk at Walmart or packing boxes for Amazon than you can as a home care aide. And then also because people jump between employers for small wage differences. Okay, so let's say there's not going to be enough home care aides. The fallback mechanism, as you all know, is unpaid family caregivers. And in fact, there's a lot of them. The AARP estimates that there's about 43 million unpaid family caregivers out there today. I think the number is considerably less, but it's still huge. It's 21 million, in my view. And remember, there was about 3.5 million paid direct care workers. So you can see that most long-term care is still given by unpaid family members. And they do it out of love. They do it because they care for their relatives and their parents, but they're under tremendous stress. How much time do they put into it? These are data from a survey, and I analyzed the survey. Most unpaid family caregivers spend less than an hour a day, but there's a tail of people who spend 3, 4, 8, or more than 8 hours a day as unpaid family caregivers. So yes, a lot of unpaid family caregivers might show up in the morning to prepare breakfast, might show up in the evening to prepare dinner, and that's it. But lots of people are there for a lot of hours of the day, and it's just hugely difficult as well as rewarding. The problem is that there are going to be fewer of these people. So this is just demographics. Unpaid family caregivers come from say the 40 to 55, 60-year-old range of the population. The ratio of people in that demographic to the people in the older demographic, 65 plus, is going to decline over time. That is to say, for every 65-year-old, there's going to be fewer and fewer younger people who are simply available to be family caregivers. And so that's going to exacerbate the crisis of the shortage of paid direct care workers, because there's going to be relatively fewer available family caregivers. Okay, so we want to move the slide. Greg, I'm frozen. Okay, even my projections of the problem may be too optimistic. If immigration is restricted, I already told you that about just under 30% of paid direct care workers are immigrants, and in some parts of the country, far more. This is going to negatively impact the availability of paid direct care workers, unquestionably. Walmart's raised its pay, Target's raised its pay, and Amazon has raised its pay. And people who go in to become direct care workers, actually, most of them, or many of them, love their job. I interviewed lots of people. They love their job. They like caring for people. But if you can make $11 an hour as a direct care worker, or $15 an hour at Walmart, Target, or Amazon, that's a tough choice. And it's going to make it harder and harder. And the Walmart, Targets, Amazons of this world can respond to the market by raising wages. And to the extent that wages are restrained by reimbursement rates, they're not responsive to the market. Technology, this is my favorite New Yorker cover. Technology, will that save us? No, it won't save us. Technology will improve care. It will enable better communications with the health team through iPads, through various kind of visual devices. You can have all kinds of smart whiz-bang things in your home, smart refrigerators, beds that track bed sores. In nursing homes, you can have technology helping with lifting. But unlike other fields, technology is not going to replace the contact. You're not going to have a robot taking care of your mother without a person also taking care of your mother. So technology will improve long-term care, but it won't be labor saving. Now, one thing that's not on this slide, that technology will also enable people to stay at home longer, right? So ride-sharing services, the Lyfts of this world, will enable people to stay at home because they'll have some mobility. They won't have to drive as much. But again, it's not going to save labor in terms of the direct care workforce. So how do you solve all this? What's the solution to this? The solution is to improve the job. But what does that mean? It means expand the scope of practice. Let aides do more. Train them so they can do it. Shift more work to the aides, saving the system money, and I'll describe how it saves the system money, and then claim a share of those savings for the aides. So it involves fundamentally rethinking the nature of the job itself. I've mentioned scope of practice. This is a particularly absurd example of scope of practice limitations in the law today. In this particular state, an aide is not allowed to put eye drops in the client's eyes. They have to guide the client's hand to the eye, and the client then squeezes the dropper. Now, of course, you know what really happens, but that's not the point. The point is that this represents the restrictions inherent in all these nurse practice acts. Letting aides do more is consistent with a broader set of trends in healthcare. Emphasis on managing chronic conditions, which saves a lot of money, diabetes, for example. Managing transitions out of acute care into homes so you can avoid much more expensive nursing homes. Healthcare delivered by teams with people working to the top of their license, and much greater use of other non-licensed personnel such as medical assistants and community healthcare workers. So improving the scope of practice of aides is consistent with all of this. Is there any evidence out there that if aides could do more, it would work, it would have a positive impact? The book has a description of a bunch of small demonstrations involving aides, involving hospitals, involving comparable occupations that suggest to me strongly that aides, if they did more, could help with chronic conditions, make transitions out of hospitals more effective, keep people out of nursing homes. But as I've said repeatedly, what you really need is data on this, and we don't have them. Enough data. There's also evidence in nursing homes that certified nursing assistants could do more. There's this movement out there called culture change, which expands the scope of practice of CNAs. Greenhouse nursing homes radically improves the scope of practice of CNAs. PACE is a particular subvariant of integrating Medicaid and Medicare funding, and also involves the aides, the CNA as part of the healthcare team. These have been evaluated, and they all show better outcomes for clients in those nursing homes. You need to train, if you're going to let aides do more, you need to train them. Half of states have no training requirements at all for personal care aides. That's one of the subgroups of home health care aides. Only a third have minimal training requirements for aids that are eligible to be reimbursed by Medicare. And again, there are a few demonstrations out there that show that if you train aides, they're happy to be trained, they want to get trained more, and they can absorb the training. These are some more examples of particularly nursing home innovations trying to improve the scope of practice of CNAs. And there are a few examples in a few states of broader job categories for aides, medication aides, physical therapy aides, and the like. Why shouldn't we do this? Why shouldn't we improve scope of practice and do more training? Well, there's a subset of home health care called consumer-directed care, in which the client hires and trains his or her own aide. They're reimbursed by Medicaid. In consumer-directed care, there are no scope of practice limitations because, in effect, the aide is an extension of yourself. There's no evidence of worse outcomes in consumer-directed care than there is in care through home health agencies. So if there's no worse outcomes in consumer-directed care and the aides can do anything they want, that undermines the notion that there would be dire consequences to expanding scope of practice. And along the same line, unpaid family caregivers are being trained to do more quasi-medical and medical tasks, and again, no negative evidence with respect to that. Who should care about anything I just said? Well, who has power in the system? The power in the system is in the hands of the insurance companies and state Medicaid officials. They're under tremendous financial pressure. Insurance companies are now increasingly running what's called managed care for long-term care, in which they are at risk. They can make a profit if they can deliver quality care at a lower cost, or they can lose money. It's in their interest to find ways to save money in the system. Similarly, Medicaid programs, as I've already said, are under tremendous financial pressure. It's in their interest to save money in the system. And these are the people with power in the system. And how can they save money? So the story I've told you would lead to higher wages and more training costs, but the benefits exceed those considerably. There'd be fewer visits to emergency rooms because aides would be trained not to just simply call 911 when there's a problem. There'd be fewer nursing home admissions, which are much more expensive than home care. There'd be fewer rehospitalizations. And very importantly, there'd be better and cheaper care for long-term chronic conditions. The savings from all of this would outweigh the cost of higher wages and higher training investments. And that's why the power players in the system should care about this. It would help a lot to have a serious national demonstration about all this story. And of course, as I've said, we don't have one, and we're not close to having one. So employers, agencies should also be interested because they can't find people. The nursing homes should be interested because they can't find people either. And if they can improve compensation and improve the scope of practice so that being an aide or being a CNA was seen as an entry point into the medical career, they too would be supportive of this and find and able to expand the supply of aides. So what are the politics? Changing scope of practice is very, very difficult. It's a state-by-state fight. And in the states that have tried to do it, they've come up against the nurses, either nurses associations or nursing unions. Most states, it's associations. The nurses resist this in various ways. The Medicaid system and the Medicare system are typically not well aligned. One of the savings in the system, from what I've described to you, would be fewer emergency room visits, for example, and fewer rehospitalizations. If Medicaid invested in training aides and expanding their scope of practice, and the savings was fewer hospitalizations and fewer ER visits, that's a saving that accrues to Medicare, not to Medicaid. And so there's some misalignment in the structure here. I've already described to you the negative attitude in healthcare towards long-term care and also towards these aides. And there's politics within the long-term care, home care community. Elements of the disability community, particularly the younger disability community, resist government-imposed standards, either with respect to quality or with respect to training. They view it as Basically, I'm in charge of my own body, and I will determine who does what and how they're trained. And that has led to conflict between advocates for the aides and advocates for the disability community. So the politics around this is extremely complicated. But on the plus side, the projections of shortages are dramatic. There's real opportunities to save money, and muddling through just relying on family caregivers is going to be increasingly dysfunctional. It's consistent with broader trends in healthcare. And my final point, when you look at all this, fundamentally change will take place because this is an opportunity that's waiting some political leadership. There's a coalition out there. And the coalition are the people who need long-term care, the exploding numbers. It's a coalition that cuts across all income groups and all social classes. And there's a coalition, the other element of the coalition is the workforce. And that coalition at some point will become attractive to political leadership. And when it becomes sufficiently attractive, I think that's when you'll see some real change in the system, hopefully change along the lines I've described. So I'm done. Thank you very much.
Great. Thank you, Paul. As a reminder to our participants, please type in your questions in the Q&A panel in the Zoom interface. And while you're doing that, I'll take a moment to tell you about some upcoming Sloan Alumni online events. On February 14th, we will have Gail Grader from the Sloan Career Development Office joining us in a continuation of our popular career series. She will be speaking on career changeability and will provide a framework for identifying the type and degree of change you'd like to make in your career, as well as diving into the factors needed to make a successful career change. In addition, we are pleased to be partnering with the MIT Sloan Boston Alumni Association on February 26th to webcast an alumni panel on the topic of investment real estate and second homes. You can register on the MIT Sloan Alumni online website, where you'll also find links to previously recorded sessions. You'll also find the full lineup of events for the spring. And now for our Q&A, we've had some good questions coming in, as well as pre-submitted via registration. Well, a lot of what you've been discussing has focused on the US-based workforce, but many folks have been asking, what comparables do we see internationally, or are there lessons to be learned in particular from other countries like Japan? If you have any comment on that.
Yeah, that's a good question. I have to admit with a certain amount of embarrassment that I did not do much work understanding international issues. The reason I didn't is because the overall structure is so different. In Spain, for example, a country that I happen to know quite well, it's a very, very strong public health system in which everyone is guaranteed a level of health care, including a level of long-term care. In some countries, there's much broader unionization of the direct care workforce than there is in this country, in which unionization is quite weak. In other countries, the tradition is you never live very far from your mother. And so family caregiving is less of a burden. So I'm not trying to defend the fact that I don't really have much to say about international comparisons, but if you want to make international comparisons, you have to take into account very different institutional structures. I will say that in European countries where there's a strong union movement, there's considerably more training for these people and better compensation. The prospects of extensive unionization of our direct care workforce, I think, are not great.
Great, thank you. And you mentioned this briefly on one of your slides, but certainly immigration and reform is something that has dominated the news cycle in the United States. But could you say a bit more about that?
Yeah, I'm not going to get into my views about immigration reform more generally, but I will say that now, as I said, about 30% of aides are immigrants. The immigrant workforce, and I interviewed quite a few of them, they often come from countries where there's a much more of a tradition of kind of caregiving. People, a lot of aides I talked to almost had a religious view about taking care of other people. There's much more enjoyment, or there is substantial enjoyment out of the work, even though it's low-paid work. And in some parts of the country, long-term care is just driven by immigrants. Um, and so if immigration is cut off, that's going to exacerbate radically the supply of these folks, these long-term care workers. And so leaving aside all the debates about immigration more generally, it's going to be a disaster for long-term care. I think no question about that.
Certainly, thank you. Um, so acknowledging early on in your presentation, you mentioned that what we often call the long-term care system is really not a system. But one question that came in is, what role might those who are somewhat outside of the quote system play? So, for example, entrepreneurs. Is there opportunity for companies? One example is Home Team
Right.
that upskills and trains caregivers.
Right.
What role do you see for entrepreneurs?
Sure. So a number of innovative home care agencies, basically online agencies, have opened up in the last few years. Their structure is essentially that of an agency, but rather than a physical location, both the client and the aide interacts with the agency via the web. That's one model. Another model are these kind of bulletin boards like care.com and so on, which are essentially matching services between aides and clients. If you look at these agencies, these online agencies, I think it's a model totally worth exploring. The one issue to keep in mind is with home care, you need a support structure such that, imagine that you've hired an aide and the aide doesn't come in that day because it's 40 degrees below, or because the aide is sick or whatever. You need to have a phone number that you can call to get backup. So these things can't just simply be online boards in which there's no human backup. Nonetheless, I think the model is promising for a variety of reasons, but it's not a model that overcomes the fundamental problem that I've described. That is to say, limitations on scope of practice. Just because you're running an agency online doesn't mean that you're free of the regulations around the field. If it's via Medicaid or Medicare, you're limited to their reimbursement rates. If it's private pay, you still face Nurse Practice Act restrictions. So you haven't solved the fundamental problem. You may have invented a more efficient way of matching clients and aides, and I think that's fine and promising, but it doesn't address the fundamental weakness of the system.
Thanks, Paul. We've had a number of questions come in. Certainly this can be a pretty emotionally and financially fraught topic for many people. And so, how do we, as consumers or potential consumers of a home healthcare service, how can we help with this issue?
So the path that I laid out, namely finding ways to expand the scope of practice, put more money into the system, train these people better, is a path that ultimately has to be a political path. Under Obamacare, the Affordable Care Act, there actually was a provision in that act called the Class Act, which was a long-term care government-supported long-term care insurance program. The Obama administration never implemented it because it wasn't mandatory, and therefore you'd have adverse selection. Only people who needed it would sign up for it, and it's not viable under those terms. But there was this kind of there was this moment in which there was political support for doing something around fixing the long-term care system. That's what we really need. I mean, there's all kinds of things that people can do as individuals to make things better for their family members, to make things better for their neighbors or for their friends. But if we're going to fix the system as a whole, it's going to require political action at both the state and at the federal level, and it's going to require a constituency that cares about it. And I'll just say again, this is not an issue that cuts across income lines. This is an issue that affects all income groups. And so there's got to be an opportunity to build a political coalition around making long-term care a better system for everybody.
Thank you. So switching gears a little bit, you mentioned technology in your presentation. and that it would, of course, improve care and communication, but it's unlikely to replace workers. And of course, we love that New Yorker cover with the robots walking around. Um, but do you think there's a role for technology to improve caregiver training and efficiency, and kind of, then increasing the ability for them to, work with more patients, increase the volume, per se?
Well, yeah, I mean, that was a two-part question. Is there a way to use technology to improve training? The answer is yes. I mean, the same lessons that we're learning about uh, web enhanced training or training people via computers or MOOCs or whatever could be applied to training aides. Now, keeping in mind that a lot of what an aide needs to do involves touching people, talking to people, dealing with people. You're never going to get away. You're never going to be able to do it all in a disembodied way. But as a matter of pedagogy, could you use technology to improve training? Of course you could. Could you use technology to improve the efficiency of aides? Absolutely. You could use technology to enable the aide to communicate more effectively with a nurse or a doctor if the aide sees some kind of problem, for example. You could also use technology to enable a senior aide to act as a mentor to another aide who's isolated in a home, and a senior aide can talk to that younger aide or that less experienced aide and provide guidance and feedback. So there's all kinds of positive things technology can do, all kinds of them. I don't mean to imply that there isn't. What's not going to happen is you're not going to have mom at home with a robot or mom at home alone. You're still going to have to, if mom needs help, you're going to need a human being there.
Right, right. Thank you. So if we had a crystal ball and project out a little bit, how do you see the landscape for long-term care ultimately changing in, 5 years, 10 years?
Well, I think one possibility is that as the baby boom really retires in large numbers, there's going to be an explosion of demand for improving the system. That's what's going to happen. I mean, the numbers are huge, and people are going to need help. People are living longer. They're going to need help. And the other point to make, which I mentioned but I didn't emphasize, is that people want to stay at home. They don't want to go into a nursing home. Assisted living is a better outcome than a nursing home for most people, but most people can't afford assisted living. It's private pay and very expensive. So people want to stay at home. And when in the huge numbers they discover they can't find somebody to help them, there's going to be a problem, and hopefully there'll be a response.
Which leads me to my next question. Paul, what gives you hope in your research and in the work you've done? What inspiring words could we share with the viewers?
Well, I will say this. I mean, I talked to a lot of aides, and overwhelmingly, these were people who cared about their job, who wanted to take care of their clients. A lot of the aides I talked to went out of their way. They went to the hospital with their clients. They worked on their own time with their clients. These are people who, by and large, who really care about helping. As I said at the beginning, most people in the medical system also care. This is a system in which people are in medical care at every level because they want to help people. The problem is the kind of institutional structures that are making it difficult to make this better. So if the politics around this can change, I think there's a lot of goodwill on everybody's part.
Certainly, certainly. So this next question may be a bit specific, but feel free to redirect. Have you seen any overlap with considerations around, for example, Alzheimer's care? So is there, as you think of an increase in demand for care, is it directly related to aging, or are there specific
Sure.
care needs?
Sure. So what's going to happen, first, just the facts is that as people live longer, there's going to be higher incidence of dementia. And dementia is more challenging to take care of people, and they increasingly will need help. My one interaction with Alzheimer's was I did some interviews at the Alzheimer's Association in New York, Alzheimer's Society in New York, where they do run a program for aides specifically around dealing with Alzheimer's patients. I'm not an expert on treating Alzheimer's, but I was very impressed with this, with this training. And I was also impressed by the fact that the aides who were in it were volunteering their own time to get the training so they could do better with their clients, which speaks to the earlier comment I made. So training aides with a specialty in dementia care, I think is absolutely a good thing to do and is the direction to go. And it's along the same lines that I talked about. It's expanding scope of practice, expanding skills so that they can do a better job for their clients and save the system money.
Thank you. Paul, a few questions have come in related to your book. So do you want to say anything about that?
About what? For those of you out there who write books, as you write a book, send it to the publisher kind of sits on it, and then by the time the book comes out, you almost forgot you wrote it. No, I don't know what to say. I mean, I will say that, I've written, I don't know how many, 6 or 7 books, something like that. This book has got more attention than most of those because this is an issue that affects everybody. Everybody has a story. Everybody has a family member. Everybody has a friend. And this is just a big societal issue. And kind of the reaction I've had to the book just reinforces that.
Thank you. I think we're getting close to the top of the hour, so I want to maybe wrap up, but could you tell us, as a final question, what are you working on now that's most exciting to you, and what's ahead?
What I'm working on, MIT established a Work of the Future task force. Going back to that New Yorker cartoon, I mean, our perspective on this task force is not that robots will take over the jobs, but that jobs are going to change. And so the task force is about trying to understand that. I'm chair of the subgroup responsible for understanding skills and training. So I'm doing a lot of work right now in understanding kind of training systems to enable people to do better as technology changes jobs. So that's using up a lot of my time now.
Paul, thank you so much. We'd like to thank you for joining us for Sloan Alumni Online, and thanks to our viewers. To keep this conversation going over social media, please use the hashtag SloanieChat. Following this event, all registrants will receive a survey via email, as well as a link to the recording. So please fill that out and let us know your feedback on this session, as well as our ongoing lineup of events for the fall. As always, you can reach out to us at sloanalumnionline@mit.edu. Thanks again for joining us, and thank you, Paul.
Thank you.